In this week's video, I want to present a live case exhibiting research that we covered 2 weeks ago in the video on B vitamin deficiency and brain melting. You may remember the video if you were present or had seen it. If not, it looks like this. This is the thumbnail for the video on my YouTube channel where we covered the research looking and stating that your quote unquote normal B12 level is melting your brain. And so, as stated today, I want to show you a real case from my office where this is happening to a 68-year-old female. And she's been through the ringer with conventional medicine. They can diagnose her with mild cognitive impairment, but they don't have anything to offer her. And so, given that her husband was not happy with, the lack of answers, so they sought out functional medicine and myself. And through the detective work you'll see today, we are finding root causes that if we can optimize them and improve them, we're excited to see what will that yield in terms of cognition and brain function and quality of life. So really exciting things. And again, reading the research is one thing, but then seeing it in real life is another thing, and recognizing it clinically and being able to take action is the mecca. So again, today's video is taking 2 weeks ago's video and applying it in real life. And so as a review from that video, the paper we looked at was from the Annals of Neurology in 2025 with the title Vitamin B12 Levels Association with Functional and Structural Biomarkers of Central Nervous System Injury in Older Adults. And remember that they were looking at older adults and seeing that when they have low B12 levels, that was having a negative impact on the integrity of the myelin sheaths in their nervous system, which is the blue things on these nerves right here. These blue tube-like structures are the myelin that cover the nerve, which is the yellow structure. And remember, the myelin allows your brain and your nervous system to conduct signals faster. And when you lose myelin, you have slower cognitive processing, slower nervous system function overall, and that could depend on where in the brain or nervous system that's impacting you. That could yield memory loss or movement disorders or multiple sclerosis or various things. And so in order to make the myelin, you require vitamin B12. If you don't have enough B12, you don't make sufficient myelin, and then you have issues. And so we're going to see that today. So a little bit about the patient. She's a 68-year-old female, as stated previously. She's 5'7", 187 pounds. On her medical grade body composition test, she had 40% body fat, and she had a visceral fat that was 74% above normal levels. And so at any age, you don't want to have over 100. Her score was 174. And so that is way too much visceral fat. Visceral fat is the fat that surrounds our organs. Now, we need normal amounts of it to surround our organs and cushion them. So when we're running and bouncing and falling and jostling our organs around, they don't get bruised or damaged. But too much visceral fat is the metabolically unhealthy fat. That's the fat that drives inflammation and increases cardiovascular disease risk, etc. So you don't want too much visceral fat. She also has a multi-year history of lab high triglycerides. We'll see that later on. And triglycerides when those are elevated, that suggests poor blood sugar handling. So we'll return to that. But she presented to me, again, suffering for multiple years with mild cognitive impairment. Back in 2020 is when she was first diagnosed with it. And remember that mild cognitive impairment is the precursor to a dementia diagnosis and perhaps an Alzheimer's diagnosis. So you don't have dementia or Alzheimer's before first having mild cognitive impairment. Okay, so she's had the MCI diagnosis for about 5 years when she first presented with me. Her main symptom is short-term memory loss. And that manifests as difficulty remembering events, misplacing things and having trouble retracing her steps to where she saw it last or where she used it last or where she put it down. She doesn't remember locations or addresses well, so that makes it hard to get around, right? She has a tendency towards anxiety and is easily startled. Now, anxiety and easily startled suggest stress and sympathetic nervous system activation. Well, the sympathetic nervous system is the fight or flight side of the nervous system, right? So, what's interesting is that the hippocampus is the part of the brain that degenerates in dementia, and the hippocampus has the most cortisol receptors of any part of the brain. So, if you are chronically stressed, you are chronically activating those cortisol receptors in the hippocampus, and that can lead to cortisol resistance. And now you can have atrophy of the hippocampus, which leads to dementia. So the tendency towards anxiety and easily startled, easily stressed, it's kind of like always on high alert looking for that tiger. And if that's happening long term and chronically, that's working against her short-term memory and her, brain health related to that. Sleep disturbance. She has difficulty falling asleep. When she finally does fall asleep, she wakes multiple times a night. And one reason for that is snoring and potential oxygenation issues associated with that. So we've talked many times on this channel about the adverse effects of sleep disturbance. Remember that we must sleep to heal. Remember that when we sleep is when the brain is taking a bath. I've made videos in the past about the glymphatic system, which is like a lymphatic system in the brain that literally washes the brain while we sleep. Well, if we're sleep deprived, we're not getting that brain bath, and now we have more buildup of protein aggregates like tau proteins and beta amyloid, which accumulate in the brain and are associated with dementia. So we must sleep to have a healthy brain. She's not sleeping well. So that's another contributor. Moving forward, just as a review from the research from a couple weeks ago, this will be relevant here in a moment when we look at her labs. But as a reminder, in the United States, the cutoff value for B12 deficiency is currently defined as below 148 picomoles per liter. This value was simply calculated as 3 standard deviations below the US population average, independent of clinical observations. So again, how is the normal range set? Pretty much arbitrarily, just by doing 3 standard deviations from average. But again, that's not taking into account clinical observations or the patient in front of you. So you can miss a lot of people by doing it that way. And the American Society for Nutrition and others think that is happening. So the American Society of Nutrition argued that more than 5% of patients who have a syndrome consistent with B12 deficiency and respond to B12 supplementation have blood levels above the 148. In other words, they're being missed because their level isn't bad enough to be considered lab low yet. Other studies demonstrated that B vitamin supplementation was beneficial in people with clinical symptoms of B12 deficiency, regardless of their blood level of B12. Selecting a cutoff value based on clinical observations would better reduce disparities in B12 deficiency diagnosis and management. And then the bottom paragraph there, cases of biochemical B12 deficiency where suboptimal B12 levels have been reported without overt clinical symptoms have been reported as subclinical cobalamin deficiency or functionally low in a functional medicine lingo. So again, you don't have to be lab low to have pathology or to have an issue. But where you get hurt is that the conventional medical doctors will not diagnose you with anything until you're below that defined lab low level. And so you can be in their office crying that your life is being destroyed, and they're saying, no, you're normal. We don't know. So we have to do better. Moving over to the right, the study says our findings are of critical importance for rethinking the biologically sufficient levels of B12. So forget about what lab low is. We want to know what's optimal, right? And we want to know what functionally low is or anything suboptimal. The population-based studies that defined healthy micronutrient levels may have missed the subclinical manifestations of low or high B12 at the extremes of the population distribution that can affect people without causing overt symptoms. Our findings support the idea that subtle neurological deficits manifest at higher levels than the current threshold defined for deficiency. And most importantly, it could provide an explanation for the often reported discrepancy between cellular and neurological symptoms. So basically what that paragraph is saying is that the lab says lab low is anything below 148. So until you're below the 148 level, you're not diagnosable in their eyes. Okay, but if high is at that end and optimal is right here, right? This paragraph is saying our findings support that there are patients with higher than 148 that have subtle neurological deficits that are being missed because they fall here or here or here. And the doctor's only looking at this as, I'm not diagnosing you till you're below there. So those patients have to continue to get worse until they reach that level to receive a diagnosis. Why not catch them here so they never have to suffer that much? That's what these authors are saying, and that's what I agree should happen. So how did our patients' levels look? Remember, 148 is the cutoff that is used. All right, so here are the levels for this patient. If we look at first B12, because that's what we've been talking about so far, her serum B12 would have been in the normal range of this lab and in the normal range of the level used by that research paper of 148 as the low end, right? So at 284, this patient's going to be ignored by every medical doctor she sees if they even run this test, because they'll tell her she's normal. Well, on a scale of 232 to 1200, does 284 look optimal? Not at all. Okay, that's at least functionally low. But we know from the Annals of Neurology paper that this is going to be driving subtle neurological deficits, or has the potential to. Well, we're talking about a 68-year-old female with diagnosed mild cognitive impairment and no other quote unquote abnormal findings by conventional medicine. Well, look what my functional medicine testing found. Lots of abnormal findings. She has low B12, okay, defined by the study we just looked at. And that study is saying low B12 is brain melting. It's damaging myelin integrity. Without myelin integrity, we can have short-term memory loss and dementia. So there's just that by itself is actionable clinically. But then look at this. Her folate, which is vitamin B9, is lab low. And don't be fooled by this reference range. That's terrible. You want it to be above 20. Okay, so this is very low folate, vitamin B9. Remember that B vitamins are required nutrient cofactors for hundreds of enzyme reactions in the body. Folate is crucial if you're someone who reads health blogs and everything. Folate is the required nutrient cofactor for what gene? M, T, H, F, R gene, right? And that gene has to function to produce the enzyme of the same name, methyl tetrahydrofolate reductase enzyme, which drives the methylation cycle. And methylation is a process that's a detox pathway, but it also turns genes on and off. All right. So if you're not methylating well, you're not turning genes on and off well, your physiology is not functioning well. Well, the methylation cycle looks like two gears. Okay. And this box right here is the MTHFR gene. Well, this wheel needs to turn this way, and it can't without proper function here, and proper function there requires vitamin B9 or folate. Oh, sorry for the terrible handwriting. So for this wheel to turn this way, that turns this wheel this way. And this wheel right here, there's a box where B12 is required. So here's another spot for B12. And when this wheel turns this way, methylation occurs by methionine giving up a part of itself called a methyl group, which is CH4. CH3. And then methionine, because it gave up a piece of itself, is now homocysteine. So homocysteine is a waste product of the methylation cycle. When this builds up, that's toxic to heart, kidneys, and brain. It can drive dementia through what's called neuroexcitotoxicity. It literally blows up neurons. Well, in an appropriately functioning methylation cycle, these wheels keep turning, these gears keep turning, and the homocysteine is recycled to methionine, back to homocysteine, methionine, homocysteine, and we're okay. But if you don't have enough B9 and or B12, now you have a big old stick jammed in these gears and they don't turn. And now homocysteine builds up, and what do we get? Brain melting, neuroexcitotoxicity, neuron death, and also increased cardiovascular risk. So this person not only has poor B12, poor folate, but those are brain melting by themselves, but then by their impact on poor methylation, now we have sky high homocysteine. Optimal homocysteine is 7. Hers is 33. The research on neurodegeneration, like Parkinson's and dementia, says that anything above 10, you're blowing up neurons at an accelerated rate. She's a 33. This is literally brain melting, excitotoxic. The research also says for every 5-point drop in homocysteine, you get up to a 50% reduction in risk of death from all causes. So bang for our clinical action, getting homocysteine down is massive in her case because she needs to drop 25 points just about. Okay, so, conventional medicine doesn't run this marker. And look, hidden in plain sight, oh, there's something actionable. Maybe she'd get cognition back if she wasn't blowing up her brain constantly. Other factors at play here, we can see her CRP is functionally high. This is a systemic inflammation marker. So again, inflammation in general worsens symptoms, whatever they are. Uric acid we'll talk about in a minute, but that's elevated. And then again, specific to brain, well, whole body, but the brain's the conversation here, is her CoQ10 is lab low. The brain needs fuel and brain needs energy. Energy is called ATP. That's the energy currency in our body. Well, ATP is made by the mitochondria in our cells. And highly metabolic cells need more ATP. Highly metabolic cells have more mitochondria. So the organs with the most mitochondria are things like brain, heart, kidney, etc. Right? So in order for the mitochondria to make ATP, they require CoQ10 in the electron transport chain to finish in complex 3 to nearly finish the process. So if you don't have CoQ10, you're not making energy well, and your brain's not going to function well. What drug causes deficiency in CoQ10? Statins. What is the symptom profile for statins? Short or long? Very long. Patients on statins often have a long list of complaints: muscle pain, joint pain, memory loss, fatigue, brain fog, transient global amnesia, all kinds of issues. Why? Well, because that drug causes this CoQ10 deficiency. So whether or not you're on a statin drug, if you have low CoQ10 like she does, it's like you're on a statin drug and you may have those similar symptoms. So this is a big time contributor to the brain dysfunction as well, because if you don't have enough energy for your brain to work, it's going to be difficult for it to work. And the electron transport chain requires CoQ10 to make the ATP. It also requires B vitamins. It also requires iron. There's multiple things. So many actionable targets here to slow the brain melting. So this part of the conversation is the manifestation of the research we covered 2 weeks ago on how B12, suboptimal B12 levels can be melting your brain. I just added, this case had that and much more that was contributing to the brain melting. So I wanted to show it to you all in one place. But wait, that's not all. If we now move on to the brain melting double whammy. Oh, wait, before we go there, I'm sorry. I just wanted to show you in the research here, they say in that paper, high homocysteine in the blood, which is a byproduct of B12 insufficiency. Low B12 and high homocysteine have profound impacts on the brain, okay, and brain structure. Our study has the additive value of showing a precursor stage at which microstructural changes are present and already impairing neurological function. So again, this low B12, even though it's not technically lab low, is at that precursor stage. She's already having symptoms. She's been diagnosed mild cognitive impairment. So why wait? Get those numbers up. In addition, older participants in our cohort exhibit a functional correlation with involvement of low B12 in maintaining myelin integrity. So again, as B12 goes down, myelin integrity suffers and cognitive function suffers. So if you want to learn more about excitotoxicity and homocysteine and what that does to the brain, I've made this video 10 years ago, and you can watch that on my YouTube channel. I'll walk you through the nuts and bolts of it. So the brain melting double whammy. We talked about the B vitamin deficiencies. Now let's talk about blood sugar and its role. Insulin resistance of the brain is considered type 3 diabetes in many scientific circles. This woman has insulin resistance globally. So it's likely she also has insulin resistance of the brain. How can we tell? Well, we can see here. Remember earlier we said she has a many-year history of lab high triglycerides. Well, high triglycerides suggest insulin resistance. Why? Well, if you don't deliver sugar to your cells, the body leaving sugar high in the blood is inflammatory. So the body wants to convert that sugar to triglycerides and store it in the liver as fat. And that's how diabetics can develop non-alcoholic fatty liver, because they're literally converting their carbs into fat, stuffing in the liver to try and save themselves. So she's got lab high triglycerides, which suggests insulin resistance. She's also got lab high uric acid. Uric acid suggests insulin resistance and especially poor handling of fructose. So fructose is a sugar found in fruits and, high fructose corn syrup and many processed foods and drinks. So if you're not metabolizing fructose well, that raises uric acid. Uric acid drives inflammation. And if you know anybody with gout, gout is a condition of much too high uric acid. And in gout patients, they want gout patients to have a uric acid level of under 6. So this woman doesn't have gout, but she has a level that is relevant to gout. So we know this is too high. Now, how about her blood sugar? Well, her hemoglobin A1C looks optimal. By itself, I would agree. Yep, that looks optimal. Her medical doctor, no doubt, is saying, yeah, your blood sugar regulation's fine, no worries. Why? Well, A1C is the average blood sugar over the last 90 days. So this looks good. But with the context of this and other things we've talked about, we should have a suspicion, maybe this isn't good. Well, the blood sugar equation is two things. It's blood sugar and it's insulin. The C peptide is the A1C for insulin. It's the average insulin over the last 90 days. Above 1.5 is suboptimal or functionally high. 2.8 is almost twice that, right? So this is how you can look at this is if you know a type 1 diabetic, what happens? Their pancreas can't make insulin, so they have to wear an insulin pump. And when they eat carbs, they have to dose themselves or give themselves X number units of insulin to keep their A1C or their blood sugar down. Okay. This woman doesn't have type 1 diabetes, so I'm using that as a metaphor. So the C peptide, anyone who has a healthy pancreas makes C peptide. It's part of the insulin process. So we could look at this as, yes, her A1C is optimal, but she's requiring too many units of insulin to keep it optimal. So in other words, she's having the insulin chaperone that's walking the blood sugar prom date up to the cell door. The insulin chaperone is having to bang way too hard and way too loud on the cell door to get the cell to open and let her in. Okay, so insulin resistance. And we can show that on a HOMA calculator by plugging in her blood sugar and insulin numbers, and anything above 2 is insulin resistance. So we can see she's insulin resistant. and she's showing about a 54% resistance. So again, if you're insulin resistant throughout your body, that would include the brain. Insulin resistance of the brain is considered type 3 diabetes. Insulin resistance of the brain, type 3 diabetes drives dementia. So this is combined with her B vitamin deficiencies to be contributing to her cognitive issues. So my question for you is, what medication is going to fix her brain? Is Namenda going to do it? Is metformin going to do it? No, right? Because there isn't a medication that's going to replace her B vitamin levels, her CoQ10 levels, optimize her blood sugar, right? Reduce her homocysteine. There's no medication that can get her out of this issue. What needs to happen is a complete lifestyle approach to replete her B vitamin levels, improve her methylation levels, improve her liver function, improve her insulin sensitivity, improve her sleep, right? Reduce her triglycerides, reduce her visceral fat, reduce her body weight. There's no drug that's going to do that. So what she needs is what she's thankfully, in her case, pursued, and that's a functional medicine practitioner. Functional medicine is what can help complex cases like this. Conventional medicine cannot, because conventional medicine is not built to do this kind of detective work. So if you're out there and you're like this woman and you've been suffering for years with a diagnosis with no root cause being discovered and no practical action steps to help you better your life, then I recommend you seek out a functional medicine practitioner to work with. And if, this video vibes with you and you like how I look at things, then reach out to me at functionalmedicincharlotte.com. All right, let's open it up.
Well, I find it to be very astounding. And I'm very thankful that there are people like you out
Appreciate
there.
it.
Yes. I feel like when I came to see you that you really helped to change the course of my life, because what I'm finding out about the hemochromatosis is that people that have that don't usually live too far past 65.
Nope.
And I'm so thankful. I'm very thankful for you and people like you.
Well, thank you. I'm thankful for the opportunity to have positively impacted you and that you've, took the bull by the horns once you were armed with the information to go advocate for yourself even further, right? Because you know that I can point you there, but if you don't take action, it was just educational, right? So you're actually implementing, and props need to go to you too, because if the knowledge doesn't do anything unless you act on it. So keep up the good work.
I have to agree with her. You've changed my life.
Thank you.
I do have a question about the B12. Are they
Sure.
different forms of B12? I thought I saw a little clip and then I couldn't get back to it. Something about different forms of a form of
Oh
B12
yeah.
not good for you.
Yeah. Yep. That's a video I've made a few times. And we made one recently entitled "How do you tell a quality supplement?" And honestly, B12 is how I do that. So if you get a supplement and you want to know, is it a quality supplement, turn it over and look at the B12 listing, and there'll be something in parentheses. It'll say something cobalamin. And
Okay.
there's basically four options. It could say cyano,
Okay.
which looks like cyanide because it is. And actually, this weekend I learned that the way they get the cyanide for the cyanocobalamin and B12, I don't know 100% if this is true, but this is what the individual I was talking to said, is they basically whip sewage sludge up into a foam and they pull the cyano off there to use for the
I heard
B12.
that.
So yeah, I hope that's not true, but even if it's not true, the cyano part goes to cyanide in our body, and that's what they use. That's what spies use to assassinate people,
Yeah.
drug people. So I wouldn't get that version.
Right.
Another one is hydroxy. Okay. And so that one's okay. This is one step removed
Okay.
from methyl.
Okay.
The next one is methyl. Oop. And methylcobalamin is the most readily used one, and that's used in that methylation cycle that I drew earlier. Okay,
Okay.
so you'll read health blogs and everything will say you need methylcobalamin. That's the best. Well, methylcobalamin is the most biologically available one, but some people over-methylate. So if they take too much of the methyl version, that might drive anxiety or other symptoms. So those people might do better with the hydroxy form because that's one step away from methyl. So their body can convert it as needed versus just being hammered with a big dose of methyl. And then the fourth type is called adenosyl cobalamin, and this one is the most useful for mitochondria. And mitochondria again are those powerhouses of our cells that make the ATP energy for us.
Okay. And I assume that the vitamins that you've prescribed for us are have the right B12 in them.
Yes,
Okay.
yes, they have the hydroxy, and that way we don't have to worry about the over methylators.
Okay. Okay, good.
So we can all just do that, take that one extra step to get there. Yep.
Okay, good.
Good
Thank you.
question.
Awesome. Thank you.
Looked that over the last time you spoke about the different types of vitamin B12.
Yeah. Yeah, it's a common question, and so just to button that up, if you see the cyano, don't get that vitamin, and that's going to be on the shelves at Target and Walmart and GNC and all those places. So you're looking for one of the other three, and the most common one is going to be methyl, but the least common one will be the adenosyl. Any other questions on this stuff?
I had one question on the folate and methylfolate. I've seen like Dr. Ben Lynch talk about folinic acid,
Yep.
how he felt like that helped him or people with the MTHFR genetic mutation, and just wanted to see how would you, I mean, is it just trial and error to figure out if folinic acid is better than MT and than the methylfolate?
Yeah, it's just you don't want the folic acid version. So folinic
Yeah.
acid or methylfolate or calcium folinate will be another name you might see that's okay. So in terms of which one's better individually, you'd have to kind of play with it, see if you notice a difference. Does that make sense?
Yep, it does.
But otherwise it's kind of like the B12 here. It's like any of them but cyano is good. So any of the others but folic acid is better. And then which one is better for the individual, you'd have to play with.
And then from absorption, let's say you've cleared out your gut issues, but you still have issues here. Like
Mhm.
how do you know if you're absorbing? You could be taking a bunch of this B vitamins, right? And
Mhm.
you don't know if should you switch to a liposomal delivery system versus the capsules and
Yeah, so you could if you're taking a bunch orally and you're not seeing numbers move, then there can be malabsorption. The gut is one area to look, but if say we've cleaned up the gut and it doesn't appear that that's it, if we're talking about B12 actually has to be absorbed by intrinsic factor, and intrinsic factor is activated in the stomach. And so if you've got issues in the stomach like H. pylori or antiparietal cell antibodies, and something that's damaging your parietal cells, then you don't make enough intrinsic factor and you don't absorb the B12 well. So you could, keep swallowing pills and it may never do it for that person. So then you say, okay, how do we deliver it in a way that skips the gut? So a liposomal could do that by, you drop it under your tongue, and that's why you hold it under there for a bit because you want it to be absorbed into the oral mucosa and hit the bloodstream directly and skip the gut that way. If that's not enough, then hey, maybe you do a subcutaneous injection, B12 injection, or an IV, or some other delivery method.